Have our first speaker, Dr. Divyansh Mishra. And Dr. Divyansh Mishra is a senior vitreoretina consultant from Shankaraya Hospital, Bangalore. And he would be speaking to us on definition and what are the various risk factors for ocular hypotony.
AV team, presentation. Divyansh. I uploaded downstairs. Yeah. So good morning all. Thank you Manisha madam for the opportunity. So the topic for presentation is definition and risk factors of ocular hypotony. So basics about it. So what is exactly an ocular hypotony, where the intraocular pressure is either less than 5 mm of Hg, which has to be recorded at least 3 times, or if it is 6.5 mm of Hg, because there are controversies whether 5 or 6.5. So both the studies suggest that 5 and 6.5, so we can take either 5 or 6.5 as an average. It can be either clinical or subclinical or acute and chronic depending upon the issues associated with it. The actual frequency or the incidence of hypotony overall is not known, but associated with surgery like glaucoma with MMC and all is 7%. With chronic inflammation like juvenile uveitis is 15%, and ocular trauma is around 7%. So this is a usual flow of aqueous from the ciliary body to the uvea or either trabecular meshwork. So either it can be because of excessive drainage of aqueous, which is outside the eye, or it can be reduced aqueous production itself. And then once the volume is decreased because the pressure is so low, the axial length of the eyeball decreases, and because of that there is inward folding of the sclera. And because of that, the choroid and retina also gets folded up, and that's how you see the folds over the retina and the choroid on the posterior pole. So the etiology depends upon whether it's an extra fluid which is lost either because of the trauma, surgeries, like if it's a leaky wound, either in via surgery or itself in a cataract surgery, or reduction in aqueous procedures, aqueous production itself, either by the chronic inflammation or topical or systemic medications, or PVR, which is pulling onto the ciliary body and causing hypotony and associated ciliary atrophy. So the ocular hypotony table is divided like either decreased aqueous production or increased aqueous outflow, and then a reversed osmotic gradient. So in this, the ciliary body hypoperfusion, as you were talking about the OIS or the ciliary body detachment, which occurs because of the PVR or chronic uveitis or capsular contraction, uveitis itself, or iatrogenic like aqueous suppressing medications if we are giving, or cyclodestructive procedures what we do, or antersegment ischemia secondary to the surgery like a strabismus surgery. If the globe is intact and we are seeing that it's increased outflow, then it can be because of the cyclodialysis cleft from where the aqueous is drained out of the choroid and then it doesn't remain in the eye. Either it can be traumatic or iatrogenic at the time of surgeries. A rheumatogenic retinal detachment or congenital syndromes like myotonic dystrophy and physiological like in pregnancy we may have it. Or if it's a compromised globe where the eye is completely collapsing, either it can be traumatic, it can be iatrogenic because of the surgeries, whatever we do, or it can be congenital weakness like in coloboma or Marfan syndrome. And reverse osmotic gradient, which occurs in severe dehydration, uremia, ketoacidosis, hyperosmolar medications, and exercises. Systemic medications which can causes like Diamox, which we usually give them for decreasing the pressures, and antihypertensive medications are also known to have little hypotony associated with it or decrease in intraocular pressure. And nitrates, antivirals like cidofovir, and hyperosmotic agents like mannitol. Systemic causes, as we were discussing, pregnancy, dehydration, uremia, diabetic coma, and Marfan syndrome, and other hereditary like myotonic dystrophy. So what exactly occurs in that? You see the hypotony maculopathy, which is usually associated, if it is long-standing, can be associated with hypotonic keratopathy also. And because of the hyperopic shift, as you were discussing, because the intraocular pressure decreases and the axial length decreases, there can be even swelling of the optic nerve head also. So it depends upon the etiology what we are dealing with. Either it can be trauma, uveitis, or an RRD. It can be associated with systemic issues, as we were discussing, from pregnancy, uremia to other systemic associations. And yes, most importantly, ocular ischemic syndrome also is one of the cause for it. As you were discussing, if there is an actual trauma, all the aqueous is drained out of the eye, and that's where you would see the hypotony. And it can be because of surgery, as you are seeing. Sometimes it can be because of the ciliary body perfusion, which is lesser, or ciliary atrophy, which can be associated with either RRD or a choroidal detachment also. Chronic sequels of hypotony, we may see a little corneal decompensations, and sometimes there can be BSK changes over the cornea. So the fundus changes, as we were seeing, with the choroidal folds, which we can see on the periphery, and there can be retinal or the macular folds, and there can be optic disc edema. And if the intraocular pressure is very low, you may see a very significant gross elevation of the optic disc. If you do an intersegment OCT, you may see a cyclodialysis cleft. And if you do a gonioscopy, this is a direct gonioscopy where you may see detachment or a cyclodialysis cleft kind of an appearance. And OCT would give you an understanding of choroidal folds, retinal folds, and even disc edemas. P-scan helps you to identify the cause, like in this case, vitreous inflammation. Sometimes the inflammation can also have CDs. There can be separation. Sometimes there is so low that it can land up into choroidal detachment with hemorrhages. And there can be a combination of both, and there can be associated retinal detachment. So the take-home message is the prognosis and the outcome of the ocular hypotony depends on the cause, like either it is traumatic or probably surgery associated. And most importantly, if you are finding a specific cause, better is to treat it like a retinal detachment or an ocular trauma, which it requires surgery. An urgent consultation with a multidisciplinary and interprofessional team needs to be taken care of, where either a glaucoma colleague or a cornea colleague or the retina itself. So thank you, and probably we may break for discussion right now, man.
I think we'll take up some questions after two talks.
Sure, thank you.
So thank you, Divyansh. And after you've highlighted all the possible